Hi, everyone. My name is Dr. Alex, back from GDR for one of our wonderful webinar series. We're very, very lucky here today to really discuss, a topic that you don't really see much around, and really a focus. We obviously do see topics, and I'm really kind of fortunate to be here with Dr. Marwan from New Zealand, who I'll introduce in a moment. But we're going to be talking about managing black triangles with a focus on ceramic veneers. But obviously, the principles can apply to any aesthetic work. And probably, some of the most challenging kind of aspects we were discussing with Marwan before when it comes to aesthetic and restorative dentistry, especially in smile and smile changes, the real kind of caliber or changes or quality can really be determined by the soft tissue. And so really excited to kind of get into this and Marwan's thoughts and his planning and rationale. So without further ado, those who do not know, Dr. Marwan Wadea, smile designer, restorative dentist based in New Zealand. Not only has he finished a dental degree, but he's also finished a master's degree in aesthetic dentistry, which is a full-time program at the University of Otago. So since then, his practice has really focused on aesthetic and restorative dentistry almost exclusively, from the way I understand. And he's partnered with another talented clinician who also does a lot of periodontal work. So we're very fortunate to have Dr. Marwan here with us. For everyone listening, these webinars are always about answering your questions. So please, for anyone who has questions, make sure to post them in the comments below, throughout. I'll get them answered definitely by the end. And just really excited for this webinar. For those listening, we also have a few updates in general. So we have our Smile Design Sydney Study Club coming up in August. For those who are in Sydney, I'll post a link as well. And then we have our last few spots for our residency cohort as well. So without further ado, I'm going to let Dr. Marwan take the stage and go through his presentation. So thank you so much, Dr. Marwan.
Thank you so much, Alex, for inviting me. It is a pleasure for me to speak with you. And I'll present a case I've done a couple of years ago. It's a challenging case. However, I would like to share with you the steps that I do follow for every single case. They are almost every single time is the same. However, every case is slightly different. So we will start. That's about me. Dr. Alex already introduced me to you. So I am a restorative dentist. So I have a 12 years experience. I'll share with you tips and tricks that you might benefit in your practice. And so the patient presented with his concern was black triangles. He's a 60 years old male. He's healthy, and his teeth generally are all right. So he didn't have pain or any concern apart from black triangles. So any patient walks into our clinic, the first thing we do is the patient would get an hour examination with me, which I'll do teeth examination only. And then that would be followed with an hour with the hygienist to do a gum examination. Once the teeth and gum examination is done, we co-diagnose the case. So we always know the patient is interested in aesthetics, but remember, the gums are the foundation, and we cannot start treating the teeth without the gum first. And the reason why, I'll show you why. So once the gum examination is done, I'll start aesthetic rehabilitation steps. They are 9 steps. So the steps are 9, however, the appointment's only 4. So you can see some appointments, we do multiple steps from the process, while other appointments, we do 1 step from the process. So the first appointment, I'll do record taking, I call it, which is different from my general teeth examination. That's aesthetic rehabilitation. So again, let me repeat. So the patient walked in, interested in whitening, let's say, or black triangles. The first thing we examine is dental examination. It's not aesthetic examination, where I'll aim for looking for disease, which is decay, for example. If the patient has any decay, so I would look into stabilizing the patient first. Stabilization phase is important, and we do stabilization before the second phase, the aesthetic or the restorative phase. The stabilization phase, usually, it's teeth and gum. we want to eliminate disease. We want to make sure that the patient is disease-free. So which one we choose first? So gum usually first. We get the oral hygiene up to standard. We need to make sure that the gum, there is no bleeding on probing, and healthy gum, no plug around. And that's the time when I'll take over. I'll make sure the patient doesn't have any decay. And once we have no gum disease, no decay, the patient is ready for the next step. So again, once the patient is ready, and that could take a few months before we start the rehabilitation process. Once the hygienist gives me the green light that the patient is periostable, it's my time to move to the next step. The first step I want to do, we call it record taking. And record taking, we take extraoral photos. Remember, in my first examination, dental examination, I do intraoral photos only. I don't look into the smile. But once we move into aesthetic rehabilitation, we start taking extraoral photos. We will do intraoral scan as well. So you can see this is from my intraoral scan. I use Medit scanner, and you can see, and then I take photos from the scan. And you can see the patient has almost all his teeth. He has missing 3-6, and he has some of his wisdom teeth, the 4-8 and the 2-8. So overall, the teeth are in a good shape. He didn't have any decay present, so we were ready to move to the next phase. And that was before the gum treatment. These are the photos that I'll take in that record taking. So the photos that we take are always the same. Straight smile photo is the most important photo. So the photo that you can see in here, this is the most important photo. This is the photo that I'll spend probably 5 minutes just to make sure I have that right photo. The photo has some criteria. The patient has to be centered because we want to see that the midline of the face that's where we're going to correlate the dental midline following the facial midline. So the patient has to be centered to the camera. And the other thing is we want a wide smile, and we want to see the incisal edges and the cusp tips of the upper teeth. We don't want the lower lip ideally we don't want the lower lip to be covering these edges because that's where I want to draw my new design. So this is the most important photo. However, this photo is not enough. It is enough to draw the new smile. However, I need more photos for me to imagine where I should position the teeth. So the straight photo is one, and it's the most important, yes. However, I'll take left and right 45 degrees, you can see in here. These photos, I'll assess the smile curve. I just want to see where the lower lip is. What about the premolars from the sides? Do I need to make them longer? Do I need to make them shorter? So it will give me another dimension because from the front, we can't see the left and right. The combination of these photos, it will allow me to imagine that the patient is looking straight to me, and then I'm looking at the patient from at 45 degrees angle. And also I'll take 2 more photos at 90 degrees angle, which is similar to these ones, but letting the patient look straight to the wall, and I take the photo at a 90 degree. The 90 degrees photos would allow me to assess incisor inclinations. And the 12 o'clock photo as well, it's quite important. And the 12 o'clock photo is where we take a photo from at a high angle. We ask the patient to chin down and take a photo at a high angle while they are smiling. The reason for this photo, I just want to see the lower lip. Where is the lower lip? And what's the inclination of these incisors? Do I need to tuck them in or tuck them out? And this, we would take it into consideration later on in our designing process. One of the most important photos we need not to forget is the lip at rest photo. This is very important photo. The lip at rest, ideally what I do, I ask the patient to breathe from their mouth and relax the upper lip. Because when we usually breathe from our mouth, we let the upper lip to rest. And then I observe the incisal edges of the upper centrals. We want to see where are the incisal edges while the lip at rest. And that's quite important for us to determine how long the new centrals we want to make them. Again, I'll repeat, you need to take gender and age into consideration, because it's different from a male to a female. Females would display more incisors while the lip at rest. The older we get, the less we're going to display from the incisors. So as the patient, as said, he's a male patient and he's 6 years old. He was -1. And how do I know -1? Once I see the upper lip would cover the incisors, I get a periodontal probe and I let it touch the incise. I put it behind the lip, touch the incisal edge, and then take a photo, or I can look at it, and that was a -1. Taking the gender and the age, I decided to make the incisal edges to be at 0 display while the patient is at rest. By this, I mean, we just wanted to make the upper centrals 1 millimeters longer. So remember, these photos are important for the smile design process. So before we move on to the smile design process, I just want you to look and appreciate in this photo the health of the gum. The gum is at utmost health, and that's after 3 months once the gum treatment is done. And that's, you can see the black triangles. The black triangles, actually, that's when they are really noticeable, because before the gum treatment, the black triangles, the extent, we couldn't see it because it was masked by the gum inflammation. And this particular patient, for him, the success of the treatment is if I manage to close the black triangles. Imagine if somebody would come and do the veneers, and later on down the line, the patient would get gum treatment, and then the gum would shrink and heal. Then we're going to get black triangles. That would be considered a failure for the patient. So that's why it's always gum treatment first, let the gum heal and shrink, and then restore second. The restorative second, because that's when the gum level's gonna settle, and that's when we want to obtain symmetry. And in this case, it's quite not easy for the reason, not because of black triangles. The black triangles, I'll tell you the tips and tricks that you need to put in mind in order to avoid getting them after the veneers. However, we have a high smile line. A high smile line case is when the patient at a smile, they would show the gum line. And when we see the gum line, it means we need to think during our preparation. So when we move towards veneers and when we prep a margin, we have 3 options usually: supragingival margin, or equigingival, or subgingival margin. So the equigingival margin, usually I would choose it in the aesthetic zone, and the supragingival margin usually in the posterior segment, because supragingival, it's quite accessible for the patient to clean them, and that's what I prefer to preserve some of the enamel. However, in the aesthetic zone, I'll aim for equigingival, which is along the gum line. But in cases of high smile line, like a case like this, it has to be subgingival. You have to hide the ceramic tooth interface. And how deep we want it to be. In this case, patient has thick biotype. He's unlikely to recede. All what I need is just 1/4 millimeter under the gum line. And that will be enough to hide that ceramic tooth interface, because that ceramic tooth interface will be visible and it will be unsightly, especially if you aim to change the color of the existing tooth with your ceramic. Once we have sudden change in color from ceramic to tooth, that interface will be visible. So I hope that's clear. These are the photos that I take, and usually after I do the ceramic treatment, I would repeat exactly the same photos. So the sequence of the photos will be done prior and during, while the patient is wearing his temporary veneers, and after. Exactly the same photo every single time, the same protocol, the same settings of the camera, same angles, and the same photos. And you can see at the end that the after the veneers, these photos would help me to get the before and after that I'll usually use for my social media. And you'll see the cases are exactly the same angle and the same color. Once I do the record taking in that appointment, usually it's an hour session. Usually I'll do bite registration, I'll do intraoral scan and extraoral photos, and then I'll start doing the smile designing process. Usually I do it in my free time, and I can do the smile design process in one day. So if the patient is coming from overseas and he wants me to turn around the case quick, so I'll ask him to come the day after, where I'll be able to go home and design the smile and then print it, because I have 3D printer in the clinic. Even though I'm at home, it connects through Wi-Fi. I can design the case and print it. In the morning, we go to work, we start processing the print, and then it will be ready for the patient for the smile test drive. So the smile design, the smile design process is very important, because remember, I said the aesthetic rehabilitation is 9-step process. If you make a mistake, if somebody would make a mistake in this step, the mistake will be carried out till the final. So need to make sure we say measure twice, cut once. We're going to do porcelain veneers, and this treatment is irreversible. We better know how much we're going to cut and where we're going to cut. And that's why spending time in the smile designing process, it is an investment. It's not only it will give you a predictable result, but also it will make you a better clinician. The reason why smile design made me a better clinician, because I believe it will make you prep better. It will make you more comfortable in the prep day. The prep day, for example, we are prepping 10 porcelain veneers. It's quite stressful, because in that day, you'll see in that appointment, we're going to do 4 steps from the 9 steps of the aesthetic rehabilitation. We're going to do prep. We're going to take a final impression, make temporaries, take the shade, take the bite. So many things are happening in that day. And the last thing you want to think is to use your brain. What I'm going to do for 1.5, for example, is it going to be veneer lay, or is it going to be a minimal prep veneer, or is it going to be a crown? But when you design your cases, that thought process already done at home. So when I come to prep the teeth, I already, while I'm prepping 1.5, I know 1.4, or for example, or I know the 2.5 will need gingivectomy, because I did the design myself. So anyways, long story short, I did develop a protocol called DSD Made Easy a few years ago. And that protocol, it is available online. And I've been teaching the protocol for other dentists. And how did I come with that protocol? Because I believe the process is complex, and I wanted to simplify the process into breaking it down into multiple simple steps and to make it predictable. And that's when I came up with DSD Made Easy. And I made it for myself to start with, to be honest, because I was frustrated with getting these cases. Then I'll end up with an incisal cant or a midline shift, which usually it would ruin the case. And I know there is a miscommunication between a technician and a clinician in this step, transferring that 2D to 3D. And that's when I came up with the protocol. And then after I tried it for 10 of my cases, I know this protocol is worth spreading it. And the reason why, the more people will be doing it, the less incisal cants we're going to see, or the less veneers redo we will end up with. So let's show you the idea. The protocol is, I'll explain to you, I'll try to break it down. We separate the smile design into 2D smile design, then a 3D. Mixing them together is quite complex, because think about it. If we want to design 10 teeth, and in order to identify the 3D position of every single tooth, we have 10 decisions to make, because we have 10 teeth. And we want to put these teeth in the ideal, the most favorable position within the face. And on the X, Y, and Z axes, it's quite hard, because so many variables and inclinations. And so what we want to do, we want to not to worry about 3D. Let's focus on 2D. So I designed my 2D using either Keynote or PowerPoint. And these softwares are available. And usually Keynote is free on Mac, and PowerPoint is widely available on Windows. So you could do it with Keynote or PowerPoint. And the idea is what we want to do is we want to draw 5 vertical lines. Remember, the first thing with the 2D smile design, in order to get facially driven smile design, is I do 5 vertical lines. The first line is the facial midline. The facial midline is the very easy to identify. We get the interpupillary distance divide by 2. So again, we use the eyes as a facial reference in order to draw the smile frame. Let me break it down easy. We have 5 vertical lines we need to draw in order to design our smile frame. The first line and the most important line is the facial midline. That's why the smile photo has to be dead center. It shouldn't have any tilt to the left or to the right. Otherwise, the dental midline will be incorrect. So when the patient is centered, we use the ears as a reference that the patient is looking straight towards us and we are in the center. So once I take that photo, I measure the pupils, the distance between the two pupils, and I divide the distance by 2, and that's my facial midline. We can see the facial midline is quite coincident with the dental midline. When I see a case like this, I know this case is going to be straightforward. The cases that are quite challenging or not straightforward is when I see the dental midline to one side and the facial midline to the other. And that's when I'll need orthodontic treatment. In a case like this, I don't need orthodontic treatment. So once we see the facial midline, now that's the center of our smile frame, and that's the dental midline. The other 2 lines that I want to draw is the inner border of the iris. So we know the pupils to find the midline of the face, but the iris, the inner border of the iris, I draw vertical lines, and that's what I call an outer boundary for the second premolar. So let's say this is the second premolar, and that's where I think will be favorable. It means it's not a must to be in here, but it is possible to expand the arch to there. However, going beyond that line usually would block the buccal corridor and would make the smile unnatural. And these 5 lines, we use the eyes as a reference to draw these 5 lines, and these will act as smile frame. It's like a boundaries for us not to go beyond. And to use as a reference, it's not a rule. It's not we have to use these lines, but I put them as a rule, and I do a smile analysis based on these lines. And a smile analysis is different to smile design. Smile design is when we create the new smile. Analysis is to see where are we at and how far are we from the ideal. So these 2 lines, let's say they guide us where the second premolars are. And the first line would guide us where the central incisors are. The other 2 lines are the inner canthus of the eye. From the inner canthus of the eyes, I draw 2 vertical lines, and that will be consistent with the canine step. So look, with 5 lines, now I know the position of 10 teeth. And how? As I said, the midline is centrals. These lines, the iris, second premolars, and the inner canthus, the canines. Then you'll say, what about the first premolar and the lateral? Easy, because out of 10, we know 6 teeth where they are. The other 4, we can easily predict them using a template I have created. I'll show you. This is the, 1 second. Okay, so yeah, sorry about that. So anyways, so this is the template. Using this template, we managed to predict where the first premolar should be and where the lateral should be. So once I put the template, and how I do it, it's a ready-made template. that I'll use for all my cases. What I do, I put one side of the template on one line, and then I would stretch the template till I touch the other line. And that's how almost the smile design process is done. So that's how easy it is. 5 vertical lines, stretch a template that I know where every tooth is. That's how easy it is. Okay, when I stretch the template, it's not only that. What I do, you can see, I position these centrals 1 millimeter below the incisal edges. And why did I do that? Because already in the prior step, I showed you while the lip at rest, we made a decision that the vertical position of these incisal edges should be at 0 display, while the lip at rest, it means we made a decision that they need to be 1 millimeter longer, and I positioned this and that lower. So the first 2 teeth that I need to worry about their position are the centrals. So I put the centrals in here in a vertical position, and the rest, I follow the lower lip. So we use the lower lip as a reference to draw the smile curve. So you can see the lower lip is curved like this. I will make the canine and premolars like that. So that's once the smile curve, which we use the lower lip as a reference, we will have a nice starting point. And that's our smile. So looking at it, this template has incorporated in it a favorable interdental proportion. So this template would give me the width to length ratio of every single tooth. So the second step, once I do the template would help me for, let's say, smile analysis and smile design. And then we do smile simulation. And the smile simulation is for the patient to see how the veneers could possibly look like, and also for me to see how these veneers could possibly look like if we go ahead with these proportions and these teeth positions. So, and here we saw only the 2D smile design. In fact, after I do the template, there is another process called 3D smile design where I use a medit link and 3D teeth library in order to obtain the final mockup. So long story short, this will not be covered in this lecture because it will take too long to cover the whole concept. It is around 2 hours long protocol. So the second step is a 3D print these wax tabs that I did, and then I'll make a putty template, which is a silicone putty over the printed models, and then I'll inject a Lexatemp and do a trial smile, which is the smile test drive. So you can see in here the plan to do 10 upper veneers and 6 lower veneers. And so again, after we do smile test drive, we will repeat the same photos that I was talking about. The smile photo, the 12 o'clock, the 45 degrees left and right. And then we're going to review it to see what the patient would think. And also me, I want to see how it could possibly look. Is it going to plan, or changes need to be done? If changes, we need to make some changes, I'll make some changes digitally and reprint the models before the prep appointment. So the smile test drive is done. Now it's time. This is the longest appointment, the teeth preparation appointment. As I said, this appointment will include teeth preparation, shade selection, final impression, and temporization. We start with the teeth preparation. I prefer chamfer margin with veneers. And I'll show you the prep. Where do we go? Because always the question is it a window prep, or is it a wraparound?
You've gone on mute, Marwan, there, sorry. Marwan, you're on mute there? Sorry, everyone. Yeah.
Sorry
wonderful.
about that. Alex, how is it going so far?
Yeah, going great. Wonderful.
All right. So the question is always I get, do we prep a veneer prep or a crown prep or 3/4 crown or wraparound? To be honest, it's defect oriented. It's not a ceramic veneer, it's a ceramic restoration. So for example, if we look at these central incisors, the prep in here is chamfer, minimal prep, to be honest. Facially, it's very conservative. Incisally, almost none. No prep was needed. On the palatal, no prep was needed. You can see it's the contact needed to be broken, and that's the only way of closing a black triangle. Again, I'll repeat, if you want to close a black triangle with ceramic veneers, you have to break the contact, and you have to discuss that with the patient. If you don't break the contact, and in order to preserve tooth structure in this area, and you would ask your technician to bulk the ceramic in this area to close the black triangle from the front, that would create a concavity on the palatal surface, and that will be a plaque trap. So if you want to do close the black triangle and create a cleansable interproximal areas, you need to break the contacts. And not only that, you need to drop the margin subgingival in this area. The reason why, in order to give some space for the ceramist to do the emergence profile nicely as it is emerging from under the gum, not bulk up right away. So that's one thing in here. You can see on the palatal, I didn't need ceramic to be there, so we didn't prep the palatal as well. So we look at the tooth and I see, where do I need to go? If I need the palatal, I need to improve the anterior guidance, and I need some ceramic in there, then of course I'll make it a full crown. But I didn't need that because I was doing the lowers as well. And you can see in here in these two premolars, the 2.5 and the 2.4, they had MOD composite, so they were structurally compromised, and these two teeth would benefit from ceramic protection on the occlusal. And you can see we did a veneer lay. A veneer lay design it's like an onlay, and it's a veneer on the buccal. So that's a veneer lay in here, a veneer lay in here. We preserve some of the enamel on the palatal because we didn't need to go 360 crown. While on the 1.4 and the 1.5, the occlusal surfaces were intact. We only wanted to close the black triangles, so we did a wraparound veneer. While the lowers, we had some crowding. Patients didn't want orthodontic treatment, and we managed to do it with wraparound veneers to close the black triangles. You can see in here, for example, it is a wraparound veneer, but these defects, for example, this is an abrasion along the root surfaces. So I would seal it like a class 5 restoration while I bond the veneer. I still have space to put some composite in there. And even in here, you can see there are some cracks. Usually I would seal them with adhesive. The shade taking, so I'll be taking multiple photos. It's very important to take stamp shade guide to show the ceramist what you want to tell the ceramist, for example, if the patient chose an A1 as a final color, you need to show the ceramist what's the abutment shade. So the ceramist would know what type of opacity or what type of layering they'll need to obtain the final result, because you give them the starting color and what's the final color, and then they will do their magic to deliver what you really need out of them. So the other see in here where you see the gray card, I'm not sure if you guys familiar with it. It is a digital shade taking called the ELAB protocol. You can read about it or check YouTube if you want. The ELAB protocol, what's it about? Where you'll have a gray card and the technician would have the same gray card. And what we do is this gray card has a reference in Photoshop. So this would allow the technician to take a photo in the lab for the ceramic and then do digital try-in using the Photoshop, because he will calibrate the color of the photo based on this card. And then he'll be able to do digital try-in outside the patient's mouth in the lab. However, to use the gray card protocol, you'll need to take polarized photos. You can see the color of these photos. There is no reflection at all because we use a polarized filter. So whenever we take shade, we try to get the color to be polarized, the light to be polarized. The reason why, because we want to eliminate the reflected light to us. We want to take the color of the dentin, ideally, because usually the color that is reflected to us is the color of the enamel. However, I take photos polarized and non-polarized, but for the gray card, take polarized. That's the protocol. So shade selection is done, and in fact, even byte registration will be taken. And that case was a simple case, didn't need any occlusal modification. So all what I did is MIP, byte record, which is the easiest to work with. Final impression, I still take an analog impression. You can do digital scan. I use digital dentistry for the planning phase, and I still do ceramic pressed Emacs, which is the analog workflow, and impression I do analog as well. So I use a hybrid protocol where I try to get the benefit of both. That's my personal preference. However, you can do it fully digitally with digital scanners getting really accurate these days. The high smile line. The high smile line, what I said we need to do subgingival finish line for the upper. For the lower, it's equigingival is more than enough, but for the upper, we need to do subgingival. This is one trick. This is important take-home message. To do that, there is one way around it. What I do, I usually prep the teeth equigingival. And after I finish my equigingival margin, what I do, I use a retraction cord, which is 000. And I'll do, for example, 10 individual retraction cords, and I'll pack them. I'll pack 10 individual small retraction cords, typically 000. And what does that do? The first cord would give us a vertical retraction for the gum. And that vertical retraction, it's almost 1/4 millimeter. And that is enough for you to create a subgingival finish line. So you can see in here, once I put the retraction cord, all of a sudden I can see a shelf of enamel my margin became super gingival all of a sudden. So what I do, I'll prep that margin again to make it equigingival again, like on the photo on the right. So even though you can see in here, the margin seems to be equigingival, the reality is this margin is excellent subgingival margin. And when do we get it? Once I remove these cords, after I take the impression of cords, the gum will bounce back and these margins will become slightly subgingival. And that's all what I want, to hide the ceramic tooth interface. I hope this was clear, how I created the subgingival finish line. To take the impression, I use the double cord technique. And in fact, whether you take a polyvinyl siloxane impression or you take a digital scan, soft tissue retraction is a must. Whatever the protocol is, it's the same. We want to push the gum beyond the margin, because what we want to send to the technician, we don't want only to send the margin. We want to send beyond the margin as well. This information that is beyond the margin would allow the technician to predict the emergence profile and the cervical contour, because that is important for the long-term gum health. So the second cord that I'll use one long cord, then I'll wrap it around all teeth like a long, like a snake. It goes all around all teeth. And that second cord purpose is not to give us vertical displacement for the gum, but horizontal. Because, even though the first one gave us vertical displacement, but the sulcus is too thin, and we want to take a bit of thickness for the silicone to be injected around these margins to give us predictable capturing the sulcus. So what we do, the second cord would give us horizontal displacement. The second cord usually will be dipped in a hemostatic agent. I typically use viscostatic clear. Viscostatic clear would, in 4 minutes, I would leave it in the sulcus, would prevent any bleeding upon removal of the second cord. You can see in here on the tooth 2.5, I did some gingivectomy for gum leveling. And even though there is gingivectomy done on the same day, with the viscostatic clear, hemostasis will be achieved usually in 4 minutes with healthy gums. And then what I do, I'll pull the second cord, leave the individual 10 cords, the single cords there, and then I'll take the impression. Then I'll make my temporaries. Temporaries, I use Lexatemp, and there are many ways of making them. In this case, I did a shrink wrap. And a shrink wrap, where we use the silicone putty, I inject the Lexatemp in the silicone putty, and I'll do Teflon rolls. Teflon rolls to give me some space for the interdental cleaning for the patient. What's a Teflon? We get PTFE tape, which is Teflon, and then we roll it into rolls, and I make 10 rolls. I put them over the papilla, which is between the teeth, and then I'll push the template over the teeth, and then I'll remove the excess Lexatemp. I'll wait 4 minutes, remove the silicone putty. I'll see the Lexatemp, and as I left Teflon in the space, this will give me some space for the patient to use interdental brushes to keep the area clean. This space is so important for the papilla to grow during the temporary stage. If you leave no space or tight area in here, you might cause the papilla to recede during these few weeks time while you are waiting for the ceramic. So it's so important to instruct and to show the patient how to use the interdental brushes to keep in between clean. And usually I would give them mouthwash as well to help, because they will not be able to floss their teeth. I'll make the veneers, of course, fused to give me some extra support. And the shrink wrap, Lexatemp will shrink while it's setting. And once it will shrink, it will technically get stuck in there. And then I'll use number 12 blades and try to clean all the excess. Then I'll use glaze from Lexatemp, OptiGlaze, where I'll paint a glaze on the temporary veneers, then I'll cure it. And that's how it will look. And that's the ceramic. It's layered Emax, handmade, of course. These are the upper. Usually when the lab work comes back from the lab, I would scan it and I would take some photos to review it before patient comes. And I would overlap the scan of the lab work over my design in order to make sure that the technician actually followed the design in regard of length and width of every single tooth. And that's how I would eliminate any error that has been occurred during the process. If there is any changes that I need to do, usually I send it back to do some modification. And then I'll ceramic bonding. It's a very important step. This would ensure the longevity of your ceramic. I usually bond under rubber dam isolation because it's the only way to guarantee and to ensure there is zero moisture contamination. And that's the only way to get optimum bond strength from ceramic to tooth structure, whether it's dentin or enamel. So, however, you can do it in any other way if you feel comfortable with. Rubber dam, it gives you peace of mind. There is no rush. There is no urgency. You can slow it down, especially when you are, if you are bonding 10 veneers together without rubber dam, you need to move fast because there is gum could bleed, or there could be crevicular fluid, or there will be moisture contamination, and usually you need to move faster. For me, I like to do rubber dam, make the field dry, clean, and do 2 veneers at a time. And usually I'll start with the centrals, of course, because these are the most important. You don't want to get the midline wrong. And once the centrals are done, I'll move to 2 at a time. And I use B4 clamps. B4 clamps really helpful. This is Brinker. The brand is Brinker. These are not rubber dam clamps. These are soft tissue retraction clamps. So they are useful for veneers bonding, where they'll push the rubber dam beyond the margin. And then there is one downside about using a rubber dam. Because it's elastic, it will have some pull over the teeth, and sometimes you lose some space. And losing space is not good, because you'll end up with a tight contact, and then it would prevent full seating of the ceramic. So you need to fine tune that margin, and you need to remove just enough, because removing too much, you'll end up with open contact. And if you don't remove enough, you might end up with an open margin and incomplete seating. So this is the downside. However, doing it slowly, you'll get better and better, and then it becomes a routine. This is right after bonding the lower. And usually what I did the upper day before, and the day after I finished the lower. You can see the gum is bleeding, but in fact, this gum will get really healthy, and I'll show you how healthy it will look like. This is not bad, because the reason why I go beyond the margin, I want to make sure that interface is so smooth, because if the junction between ceramic and tooth is so smooth, the gum will be happy for the long term. If you leave some roughness, that would accumulate some plaque and would be a chronic gum inflammation and irritation. And that's almost the final. And this is a year after. So look, the thick phenotype of the gum, it's amazing. The gum is healthy, no black triangles, patient is happy, and I'm happy as well. We didn't have any problems. However, still work in progress. There is a missing tooth. The plan is to put an implant in here and seal this abstraction and that abstraction as well. Other than that, this is, again, as I said, we repeat the same photos. And if you look at it, the objectives has been accomplished, which is closing the black triangles. And not only that, you can see this is natural result. It is almost the same, but that's what we call a smile enhancement. So if you look in here, the teeth looked all right, but in fact, the proportions they are almost very short teeth, and they don't look like teeth anymore from a lifetime of wear. And look in here, the canine is looking like canine, premolar is looking like premolars. So now it feels like the smile has been refreshed and feels like new. I hope you did enjoy the case as much as I did. Thank you so much for the opportunity, and I'm happy to answer all of your questions.
Thanks, Marwan. That was really fantastic. I think it's a great insight to see in terms of the whole full step process, and especially kind of, I guess, application of preparation design and the fundamentals there. We have one question, and please welcoming all questions, but we had a question about in thin biotype, how far, if you go any subgingival, would you place a crown or veneer margin?
If it is a high smile line, I'll do the same. I'll go slightly subgingival for the high smile line. However, I might do one chord technique only. I wouldn't use the 2-chord technique. So it depends on the sulcus. Not always we use the 2-chord. If there's space for another chord, yes. But if there isn't, we're not going to push it and damage the gum permanently. With the thin biotype, so technically being gentle with the gum, because it's not as tough as the thick biotype. However, I'll follow the same protocol, and yeah, that's all what I'll do different.
Okay. And I'll ask a few questions about perhaps periodontal cases and stage 3, 4 periodontitis as well. We have a question, could you just refresh perhaps, let's use so you kind of differentiate a little bit on the thick gum and the thin gum, perhaps not so much in the depth of preparation, which I think you said was about 1/4 millimeter subgingival.
Correct, yeah. Mm-hmm.
And perhaps maybe this is actually a good question, is how do you determine 1/4 millimeter? Well, what's your, is it a feeling? Is it the cord retraction in a thin or
Yeah,
thick situation?
usually, as I explained, the technique that I follow is I prep first equigingival. I follow the gum line. That's the initial prep for the margin. And then
And are you
I'll
doing
pack.
that, to clarify, are you doing a full prep to that margin, or is it like a partial kind of to create a margin?
It is a full prep.
Full prep, okay.
However, yeah, it is a full prep. However, the margin is, let's call it an initial prep for the margin. And then I'll pack individual cords of 000, and that usually give us 0.25 millimeters of vertical displacement for the gum. So now all of a sudden my margin became slightly supragingival, and all what I'll have to do is to drop the margin to equigingival again, which technically became subgingival. Once I take the cords, the gum will bounce back. Because usually what I use a red band handpiece. The red band handpiece would allow us to control the speed of the rotation. And once I go on dropping the margin, usually I wouldn't go on a high speed. With the prep, yes, I go on a high speed, but once I want just to drop the margin, I'll usually go on a low speed. And then usually, most of the times, I would switch the water off to give me some visibility in order to draw that minimal margin very gently. However, because it's a low speed, and I would let the dental assistant to be cooling down my prep with intermittent water air spray, and that would be just enough to make sure that there will be no heat generated. So it's just a fine, slow movement, fine, in order to draw that minimal chamfer margin.
Yeah, no, that makes sense. Another question we have is, and perhaps you talked about temporaries and the Teflon. I think one question, perhaps just re-clarifying what you've already said, is how do you remove the shrink-wrapped temporaries? Do you remove them? Are you leaving them on? I know there's lots of different approaches, or do you change your approach sometimes?
Yeah, there are many approaches, correct. Because I have, for example, my preference, whenever I break the contacts, so I have lots of area to get shrink wrap to lock in. I use this technique where I let the legs attempt to shrink and lock in, and that will be enough. But however, I'll use a Teflon interdentally to make sure it will give me space interdentally, and then I'll use number 12 blades to fine tune the space, to create more space and to remove all the overhang. However, if I have a veneer case where it is a minimal prep, no need to break the contact, shrink wrap won't work because there is no much of surface area to lock the temps in. So usually in these cases, what I do, I'll take the temps out, and usually would come out with the putty once I take the putty. And what I do, I'll finish the outside the mouth, the margin, and I'll spot etch. I'll etch one spot on the enamel of every single tooth, and then I'll put a dipping resin only. A dipping resin, it doesn't have a bonding agent. So it's only a dipping resin. Usually we use it to mold the composite, to shape it at the end of the composite filling. So it's not the same adhesive that you would use to bond composite to dentin. Because if you would use adhesive, you would bond permanently your temporaries to the teeth. But using dipping resin, which doesn't have dentin bonding agent, technically you are bonding, let's say, the temporary veneer to one spot only. So that's why we do spot edge.
Yeah.
And then what we do, and when I remove the Tams, usually I would slice the Tams, then start breaking them slowly. And then in the case of a spot edge, you would see like the temp will be still attached as a spot over that spot edge. And usually I'll use a number 12 to remove it out of the enamel, or you can use a Soflex disc, slowly remove it. So you'll need to remove this carefully. So this is another way of doing it.
Okay.
And these are the only two ways that I do. Yeah, another way is printing them. But to be honest, I haven't printed temporary veneers. I have printed temporary crowns, but with veneers, I'm not sure how this will turn out.
Yeah, no, I can see a few kind of material, and perhaps not really solving. You may have the same challenges even. Now, one of the other questions is, and I think you do, and we've kind of shared links for everyone who is interested in the DST Made Easy, but do you have a range of different smile design templates? Do you create them yourself? Do you have a library? And perhaps maybe onto that is, do you apply it perhaps differently for different patients? Or how do you use them?
I have only one template. The idea is I wanted to simplify the protocol. The reason why it's called easy, it's only one template, and I have 10 teeth library, 3D teeth, 10, which is from the second premolar to the second premolar, which would correspond to this template. And the reason why one template, because what I've noticed is all what we need is one. I know other softwares would propose with oval and triangular and rectangular and all sorts of templates. But in fact, to worry about the shape, the profile of the tooth to start with, that would give us a decision fatigue. The last thing I want to worry about is the profile of the tooth. In fact, the profile of the tooth, whether it's triangular or oval, that would be controlled with the line angles, and that could be fine-tuned with the technician. Me, all what I want to work on the macro aesthetics. I don't want to worry about the micro aesthetics. The macro is when the smile from far. All what I want to know, how long every single tooth is, ideally within the face should be, and where every single tooth should be within that smile. So the whole concept is we want what we call as facially driven smile. What's a facially driven? We want to use the face, and which are the references that we use? The eyes. Most of the references are coming from the eyes, the pupils, the iris, the inner canthus, and the facial midline. 5 lines. Once I have it with that template that I created, it's a one template. It's universal, and to do work for every single case. Not only I use it for all on fours, all on X. I use it for complete dentures, immediate complete dentures. I use it for composite veneers, ceramic veneers, because if you think about it, whether it's porcelain or ceramic, porcelain or composite veneers, the same steps, the same smile design, the same smile analysis we would follow.
So to clarify then, with the micro aesthetics, is that something that you are discussing or perhaps relaying to your technician in addition, and you're just making comments? This is the macro, this is what we're looking for. However, this is the micro little elements we want. And I imagine also in addition, when you do the smile design try-in and the kind of mock-up appointment, that's when you're kind of getting into that detail. Would I be correct to kind of say both of those things, or do you have a different approach?
You are correct. So usually in the once we go to the MeditLink, the software where it is a 3D designing software, I have a 3D teeth library, and it has the shapes and the line angles, everything in them. If someone, so with MeditLink, we always say the sky is the limit. With digital dentistry, the mind is. It's not the sky, because you can take it as far as you wish. If you love or enjoy the artistic part of dentistry, you can make your micro aesthetics to as beautiful as you want. If you are happy with everything as is, for me, I do focus on the macro to start with. I just want the midline to be right, no incisal cant. I want to know the proportions of the centrals. I want to know the inclinations of the incisors. which is what I call the incisal edge position, the vertical and the horizontal. These are the elements that I focus on. That's what would make the case or break it. The artistic details, I'll leave it to the ceramist, and usually I would send to the ceramist two impression, which is the prep, and also the mock-up. And I tell the ceramist, um, make make the mock-up in ceramic that would fit my prep. So all these steps, usually I would work on my own till I'm done. I'll send everything, the photos, the models, the impressions, to the technician, and I would sit with the technician, and we would just have a chat on the requirement about the color and shape and expectations.
Now, in your last case, you mentioned, I think, the patient didn't want to have orthodontics, and so that's why there was in the low end sizes some interproximal reduction. I mean, one of the questions was, could the case have been treated with orthodontics and IPR? I'm guessing perhaps, was there aesthetic and shape, tooth shape, color concerns on top of the, I guess, alignment and crowding concern?
Yes, correct. Orthodontics and IPR could help with black triangles. However, for 60 years old patient where the teeth are already worn down and black triangles we have, so it's not black triangles, even though the patient would say black triangles, once you eliminate them, the eye would move to the next most obvious. And right away, the other thing he'll pick, however, it is an option, but the patient, this particular patient, in orthodontic treatment has been discussed. He already had orthodontic in his childhood. He was against that. And that's why we managed to skip the orthodontic, because the teeth were only rotated. If the teeth were proclined, in these cases, we need orthodontic treatment because otherwise it will be aggressive. We need orthodontic treatment to align the teeth to the wrong inclination. And that's when I use ortho, when I have midline shift, when I have severe incisors and inclinations. With the crowding, not so much.
Yeah, that makes sense, especially in your older populations, and where there is, again, like a tooth shape, color issue. With great question. So one of the questions was also just going back to the prep and the protocol, and perhaps, again, I'm going to make a guess because it makes it makes my brain think. So one of the questions is, why do you put the retraction cord not right at the start, but after that first prep? Now, is it perhaps that you want to minimize the time the cord is subgingivally?
Yes, yes, 100%. Because yes, I usually do it at the end. I'm not sure if other clinicians would prefer putting it at the start. I think that the process of packing the cord, you just want to break the contacts first to be able to go around the teeth. If you have contacts there, you won't be able to wrap around the teeth. So you need to break the contacts anyways, and then put the cords. So if you pack the cords and draw a beautiful margin right away, equigingival, I find it quite hard because I use different speeds and different burrs to prep. So to prep the whole tooth, I use a high speed, even though it's the red band handpiece, but I make it rotate at a high speed to prep different to the margin. When it's the margin, I change my burr and I change my speed. And that's why I do it twice. I do it in 2 stages.
No, that makes sense. Now, I'm going to finish off with a final question, unless we have some more. When you have kind of more, let's say you have a kind of a moderate to severe periodontitis patient, and we have generalized, let's say, 50% bone loss. So we go through periodontal treatment. This is something I see in practice all of the time. And we have kind of, obviously extensive recession, extensive black triangles, root exposure. How do you go about communicating and restoring those situations? If you can discuss in general, I understand it's obviously very hard to discuss any detailed protocol, but is there something that these types of patients and groups you approach with?
Most of our patients are this type, that the one that you mentioned, which is restoprio. And in fact, what we've noticed, they do benefit a lot from the restorative component, because we know severe gum, most of severe periodontitis that I come across, it has an occlusal component to it. We know it's the disease itself. However, there is force management has to be addressed. For example, once the gum treatment is done with the hygienist, which is Victoria, once she does the gum treatment, and then after the 3 months, the post-initial therapy evaluation, and we have periostable, for the long term, moving forward, we need to do force management, because we understand most of the if we don't manage the forces, the teeth will stay mobile. We will keep getting bone loss regardless of managing the bacteria. It's forces, bone loss due to high forces, and these people usually the let's say mid 60s or mid 50s to mid 60s, the ones that I get, they would have either missing posterior support where they'll need teeth to be replaced, and they'll start chewing on the front teeth, and then when the front teeth start getting pushed forwards, and these will get perio treatment, then orthodontic treatment, then splinting, and then replacing the missing teeth. And most of the teeth as well, the heavy praxis patients where they damage their canines and their incisors, they'll end up with edge to edge where there will be no guidance, and they'll start rubbing the posterior teeth during excursions, and then when we see severe bone loss in the posterior teeth. So again, it depends on the case. However, I believe, and the cases that we are dealing with, that when it's all about diagnosis. If the diagnosis of the bone loss, it's a perio, doing perio treatment only is not enough. And these people, we usually do even ortho. In these cases, we do sometimes perio, ortho, and then restore. That is the sequence. It is always perio.
Yeah, no, that makes sense. Well, Dr. Marwan, thank you so much for your time, and thank you everyone for your wonderful questions and tuning in with us on a Tuesday evening. We really, really appreciate kind of everyone's time, and like I said, there's a few links in regards to Dr. Marwan's and a few things we have coming up in the comments below. So thank you again. We're excited for the next one. Have a good night, everyone.
My pleasure. Thank you so much. Good night.